All right, good afternoon, everyone. Thank you so much for taking time out of your schedule to come and attend this webinar. This is part of a new webinar series being hosted and moderated by the Iowa Heart Foundation to kind of increase education and awareness around heart health, issues, diseases, anything that we can do to bring education and awareness to heart health. This month, we are focusing on movement because it is Move More Month. And we are going to be going over kind of the basics of cardiac rehab, so Cardiac Rehab 101, and also focusing on the important role that caregivers play when it comes to cardiac rehab, adherence, and retention. So I will hand it off to our wonderful speaker, Eric Larson.
All right, thank you so much. Again, big thanks out to Iowa Heart Foundation for putting this together, again, a monthly series looking at heart health and how to promote that. And I think one of the most fitting, of course, is cardiac rehab, something that a lot of people don't know about, maybe have heard it, family member that might have gone through it and such. Typically, when I do this presentation, it's kind of clinically driven. What I've done is change it around a little bit to really kind of focus on the patient themselves or family members. I think that's important to have that knowledge for loved ones to be able to help understand exactly, what the patient's going through, but also help promote exactly what we do. Sometimes they always say we're the endpoints in cardiology. I prefer the term stepping stone. I think we are the bridge to improving someone's quality of life. And so what we want to do is present that today, and we'll go ahead and get started. So topics of discussion today, basically we're looking at the basics. Who do we serve and what do we do from A to Z? Again, we titled it Cardiac Rehab 101, very fitting. A little bit of stats, some utilization data as well. And then, of course, the referral process. Exactly how can you get into a program like this, and are you the right fit for it? I always like to start with our mission. This is kind of a nationwide utilization from our national organization, but it's basically to restore and maintain an individual's optimal physiological, psychological, social, and vocational status. We try to fully encompass the individual by not only individualizing what we do, but to capture exactly every aspect of their life, what got them where they are today, and what we can do to make that better. This is typically accomplished through a comprehensive, and I mentioned individualized exercise, education, and behavioral modification program, designed not only to improve the physical and emotional conditions of patients with heart disease, but as I'll keep coming back to, improving their overall quality of life. A few goals we set with individuals. First of all, we identify, look to modify, and manage those risk factors to reduce the disability, morbidity, and mortality. Basically, what got these individuals where they are today? What can we do to change those to increase their quality of life? Improve functional capacity, alleviate and lessen the activity-related symptoms for some folks, educate patients about the management of the heart disease in general, and of course, in bold, different color, improve their quality of life. A few core components that we look at is a baseline patient assessment. We bring an individual in. We go from A to Z with these folks to understand exactly what we're dealing with. And then we ongoingly assess the individual. We have regulations where we do that monthly, but honestly, it's almost every given day that we do those. And more detail will come out as we keep going in the presentation here. Risk factor management and lifetime modification. Exercise and activity training, which is the core. You think of rehab, you think of exercise, you think of activity, and that is the core of what we do, but there's so much more to it. So what we're going to do is kind of look at the phases of cardiac rehab. Typically, they're broken up. There's a lot of terminology that could be a little older used, and I'll kind of go into what's more utilized now. Cardiac rehab is made up of 4 phases. Kind of a terminology that was used a little more, 80s, 90s, turn of the century. Now we're looking at more of an inpatient, outpatient, maintenance type format. We'll go through each one of those. So let's first look at the inpatient side. So during an inpatient phase, the objectives mainly are to get the individual up as soon as we can, be it from an event or a procedure, depending on exactly what the patient needs. A lot of this is done to prevent muscle atrophy, prevent the negative effects of bed rest, prevent blood clot formation, prevent pneumonia, and typically we do this anywhere from about 3 to 4 times a day to try to get the folks up and walk them throughout the hallways. If they're limited, we will do things strictly in their rooms. A lot of, as well as the patient and family education, and I put family in there because this is very, very important. If you think of a family member or any patient or any type of procedure you might have been through, you're not always, comprehending or retaining the information that might be pushed in. So having a family member there is always vital. Plus, it kind of trickles into what we'll do in the outpatient side as well. And then we, of course, go over exactly how to survive and what to do at home as well. And a lot of this is their ADLs, their activities of daily living, what they do, what they're most able to do, depending on the individual. And then, of course, reduce that fear within them. Again, they went through a pretty big procedure or event, and we want to make sure that they feel comfortable being able to go home. And of course, the main thing, again, in bold here, is the referral to an outpatient facility. Again, most cities throughout the country, depending on the region, sometimes it might be just per county, do offer an outpatient facility for cardiac rehab. Straight over now to our phase 2. This is the outpatient entity. So this is typically immediately outpatient. We usually try to start individuals anywhere from about 1 to 3 weeks post-discharge following their event or procedure. It's important, again, to keep the body moving, keep the blood flow going. We don't want bed rest or any type of decrease in what we try to accomplish from an inpatient side. So we try to get them in as soon as possible. Most programs across the country do 2 to 3 times per week, depending on the patient's schedule. A little more flexible for some of our retired folks when we look at individuals that are still working, which we are seeing a lot more 40, 50, and 60-year-olds that are having procedures or events. So working with them, sometimes we even have to go just 1 time a week, where we can do a hybrid type model where we still are able to keep tabs on them, but they can continue some of this stuff more on their own. Typically, you'll see anywhere from about 6 to 12 weeks. Insurances do cover these services, and a lot of their recommendations are anywhere from about 18 to 36 sessions is where we're going to see the maximal benefits to where we can make these lifestyle changes and exercise habitual for folks. Outpatient does involve monitored exercise, so your heart rate and your EKG is continuous. We do intermittent blood pressures. Typically, most programs across the country will do a pre, during, and post. So again, we're watching very carefully. For those individuals that have lung issues, we do monitor oxygen saturation as well if needed. This is a medically supervised program. So again, we not that a doctor is right there in the room, programs that might have that great luxury. But typically 99.9% of the programs won't, but we have them readily accessible. So meaning we are physician driven. So we have a physician that is in charge on a daily basis of the care of the patients that are being seen that day. Most programs like to run about a 3-to-1 staff to patient ratio. This can fluctuate anywhere across the country, also depending on the complexity of the patient as well. Most programs I've been associated with, we look at a 3-to-1. Safety first. So a little bit of stats here. So this is statistics that are within a cardiac rehab. So 8.9 cardiac arrest per million patient hours of exercise within a cardiac rehab. That's the actual occurrence, which is pretty thing. We catch a lot of things before things happen, which is what this is basically pushing out to you. 3.4 myocardial infarctions per million patient hours, and 1.3 fatalities per million patient hours. So a little bit of the staffing that's typically involved in most programs across the country. Again, as we mentioned, we have every program has a medical director. They're there for consultation, intervention meetings with the staff, make sure we're all up to par on exactly what types of services we're providing. Registered nurses, they come in with special training, again, with advanced cardiac life support. In case of emergencies, they're able to respond appropriately. Another big aspect within the program is the exercise physiologist or specialist. These are individuals that truly did go to school for these types of services, which are great. Again, when you look at physical therapy, occupational therapy, athletic training, we all spawn from an undergrad standpoint to our different specialties. When we look at an exercise physiologist, we specifically went to school to deal with this patient population. Registered dietitians bring a great key focus to our programs. Again, unfortunately, a lot of programs aren't able to have registered dietitians in their programs, but what they can bring is that key thing of where they're changing food habits for folks, which is important. Respiratory therapists, again, this is a lot more on a pulmonary rehab side of things, but again, we still have that mix of the cardiac and pulmonary type of patient within the cardiac rehab realm. So RTs are important as well. Psychosocial support, huge. Stress, depression, anxiety. Again, a lot of that stuff leads to why people had heart issues at times as well. And those programs that are able to have psychosocial support, this is a great professional to have. Let's see, we talked about those. So one to add to that, charges for cardiac rehab services are typically covered by most insurances. A lot of programs do pre-authorizations, which is great. So we know exactly if there's any out-of-pocket expenses to a patient, they're very aware of it. So we don't want any surprises. We don't need more stress, anxiety in regards to that. So we're very upfront about what we're putting out there for the individual. Eligible diagnosis. These are these are the eligible diagnoses set forth by CMS that are covered for our services. First one we're looking at is a myocardial infarction, a heart attack. Now, this is the only one that does have a true time frame associated with it. The actual heart attack has to be within the last year to be eligible for our services. Now, typically, you're not going to see a whole lot of folks that come in with a straight diagnosis like this. Typically, there was an intervention, be it an angioplasty, a stent, or maybe the individual actually had to go in for a surgical procedure. So, but there are some that are what they term as medically managed, and that's what this falls under. CABG, and I put the acronym up there, a coronary artery bypass grafting. Everybody's heard of a bypass surgery. You've had friends, families, people in the community that might have had these procedures. They have the nice long scar down the middle of their chest. So we like to term them the part of the zipper club now. That one is associated as well. We talked about the angioplasty, the intervention where they might have stent placement or a balloon angioplasty. Stable angina. What this is, angina is chest pain. And so when we look at a stable chest pain, we're looking at something that's actually brought on with exertion. An actual contraindication for cardiac rehab would be termed as unstable angina. So if you're just sitting in your chair, not doing anything, but you start having those types of symptoms, that's actually a contraindication for what we can do and is not an eligible diagnosis. But again, that's where an intervention of some type might need to come into play. Cardiac transplant, valve surgeries, either repair or replacement. Heart failure, which is relatively new for us within the last 10 years, has been added. And how this works is individual's ejection fraction has to be 35% or less. And they do have some definitions of exactly an individual. So if they are stable, haven't had any recent hospitalizations, we can get those individuals in within 6 weeks. If they've had a procedure of some type, sometimes you have to look at it at 6 months. Again, this is defined by CMS. And the last one that was added recently is peripheral artery disease. It does fall under cardiac rehab most times. It does have kind of a separate coding entity, but they all fall within cardiac rehab. These are basically pretty strict guidelines. Most programs have sent out referral patterns or referral guidelines, physicians that typically refer these types of patients. If there is any questions, most cardiac rehab will be able to define that for individuals to be able to get someone in for that. Patients do follow a very individualized program. We have an umbrella, but again, as we spawn under that umbrella and it starts to come down, everything is individualized from their education to their exercise. So certain components within ours. So we talked about the patient assessment. This again is at the beginning, our very first session. The individual comes in themselves or with a family member, and we go over exactly everything that happens with them, physically, mentally, whatever it might be. We assess these individuals. We establish goals. If they're looking to get back to swimming at the Y or walking their dog, this is the things we make note of that we really check on occasionally to make sure that we're trying to meet these goals for these folks to get them back to what they want to do to make their quality of life better. We do submaximal exercise tests. Some programs actually do full-fledged stress tests as well. Again, it just varies on the region. The exercise training component, we incorporate both aerobic and aerobic. Most people are probably familiar with what aerobic is. This would be treadmills, bicycles, steppers, rowers, something to where the sustainable duration of keeping your heart rate up. Very extremely important. This is where the training of your heart comes into play. The other component we do is called anaerobic. And this is where muscle strength is built. Just as important as an aging population comes into play here. This can incorporate with weights, bands, different entities can be put forth there. Counseling, smoking cessation is a big one. Again, we have a lot of our baby boomers came through the system where smoking was, the cool thing to do, and it became habitual. And so now we're trying to deal with those. A lot of that on the pulmonary side of things as well. Most states offer smoking cessation programs. Very few are able to actually have smoking cessation within the program unless they have something in the hospital where they can cooperate with another department, which is great. Again, but at the state level, extremely important. Some other counseling that's offered is within the alcohol, behavioral health, and then substance abuse as well. And then, of course, we look at the management of the risk factors. Again, looking at every single thing that got them where they are today. Is it their weight? Are they obese? Their lipids. We are very honed in on this with our dietitian to make sure that eating patterns are changed, to look at more of a healthy eating environment. Blood pressure, always one of the biggest culprits. And then, of course, diabetes, which is becoming extremely more prevalent across the board. Some education that's provided. We look at the benefits of exercise. We break it down into why is stretching important? Why is weightlifting important? Everything across the board that exercise has to do with that's helping maintain that healthy heart. Exactly our theme of this educational series. Nutritional topics. We go over label reading, dining out options. What are healthy options when you do want to go to a restaurant? Because not everybody wants to cook, and we all do it. But how can you make better choices when you're at that restaurant? Your sodium, really extremely important for our congestive heart failure patients, and then overall cholesterol. The other education components we look at are the risk factors, the hypertension, the weight management, diabetes, and smoking. We break these out into weekly topics where we talk to individuals. Again, individualizing it to them. Now, of course, we're going to get some individuals that have no issues with weight. They might not be diabetic and they never smoked, but we always present the information to every individual because they might have loved ones or family members where that information with our handouts that we give might be pertinent. Medications, we go basically on a daily basis, we kind of do a medication reconciliation. And what that means is we have a list of the medications you went home on. And we review this on a daily basis verbally. It only takes a few seconds. It's nothing that we sit in a corner and talk 20, 30 minutes about, but make sure that you're on the right medications. If we see issues, we cooperate with the physicians, be it your primary, your cardiologist, your surgeon, whoever it might be. And then, of course, stress management, relaxation techniques, anxiety, and depression. These are a huge one that are oftentimes either not manageable to be able to be educated on because of staffing. And a lot of times it's as we know in society right now, these are things that are just really need to be tackled hardcore. And we try to do that with all four of these topics throughout our process. And most programs across the country do that very well. We are a physician referral required program. So from an inpatient standpoint, when an individual has a event or procedure, there are automatic things within a medical records and ordering set that is actually pushed out. So that's a nice thing now is it has become a requirement for referral to an outpatient program. Now, of course, individuals can yay or nay it. But again, the benefits outweigh, and I go over some stats here shortly of why it is so important to do this. But we are a physician required service. So this gets into some of the national guidelines in regards to that referral. So we have been classified as a 1A intervention. This is exactly the same as the medications that are prescribed to you as you go home, meaning the highest restrictive recommendation, and it has the highest level of evidence. A lot of research went into this that allowed it to become into that 1A classification. Okay, utilization. So these are going to be some startling figures that I'm going to be throwing out to you in regards to exactly who's doing our services and who is not, and how we can change that. So, oh, sorry, must have slides switched there. So ignore that for 2 seconds, but we're going to quickly go over the benefits of how cardiac rehab benefits you. So again, reduction in those symptoms, a lot of it, those chest pains, blood pressure, different things like that, things that we're trying to reduce those symptoms. Improving your exercise tolerance by hopefully making exercise habitual within the cardiac realm. You want to keep doing that. So improving that exercise tolerance is important. Improving your lipid levels, reduction in tobacco abuse. Again, all the educational entities and counseling we have available are looking at the benefits. Improved glucose tolerance, improvement in their psychosocial well-being and stress management, decreased rates of subsequent coronary events, and I have some stats that'll show that here shortly, reduce hospitalizations, and then decrease morbidity and mortality rates. Oh, and there's always my favorite, improved quality of life. Okay, so looking at the utilization, what we're trying to do is close this gap. And basically what's happened is it is highly underutilized, our services. Again, as we talked about, it is a 1A intervention, same as your medications you went home on. So a lot of studies over the last 10 to 15 years have shown that about 30 to 35% of patients actually attend cardiac rehab, which is startling. Now, again, there's a lot of reasons why they might not, and we'll get into that here very shortly. But this does represent one of the greatest quality gaps in the secondary prevention of heart disease by not utilizing the services of cardiac rehab. So some reasons why, as I mentioned 2 seconds ago, of why individuals might not be. From a patient-centered standpoint, age. Sometimes individuals are sent to rehab services or rest homes or whatever it might be. It's difficult to actually get into a structured facility. Research has shown that women are less likely to do it as well. And what we've seen that is more so in an older population where women were the caregivers at home, and they don't feel like they can leave their husbands or their families or whatever it might be. They have a lower percentage of actually participating. Non-whites, some research has been done in regards to that where individuals aren't utilizing. Insurance status is always a big one. Co-pays, out-of-pockets, it makes it a little strenuous. Again, the stress involved with that, knowing that bills can pile up is important. Some active smoking individuals have issues with wanting to be in an environment where they feel like they're going to be told they have to quit smoking or else. Not true. We don't judge, we just try to assist. That's the key thing. But again, a lot of research has been done to where active smokers do not participate. Geographically displaced individuals, so people that are more in rural areas or people that don't have the abilities per se to be able to regularly attend a type of program like this, has shown to be hampering. Language barriers is always huge. And then we look at a center-based. So we're looking at more of our reasons why it might be. The lack of referral, getting that buy-in from the physician for those that don't have automated systems to actually refer to a program. Again, gets into the providers where they don't endorse us as well as they probably could. Limited facilitation of referral. Again, trying to push that referral out to individuals. So when we look at participation rates across the country, this is kind of a dated map, but it still gives some startling information where percentages are of people that are utilizing our services could be from. Again, as we mentioned earlier, about 35% is the average participation rate. I am in Des Moines, Iowa. As you know, the Iowa Heart Foundation is the one putting this on, so I am located in Des Moines with Mercy One. We actually have the second highest, and this could be plus or minus. Some of these rates, these figures could be off slightly based off of some other data that's coming in more recently. But we sit at about 52%. We're seeing that a little bit more kind of down the middle of the country. The coasts are where it's a little bit lower, as you can see on the map there. Completion rates. So these are for individuals that actually do get into a cardiac rehab and actually what we term as graduate from our program. Some programs do some neat, elaborate cap and gown pictures, diplomas, and stuff like that, which is fantastic. I think, you know, whatever motivation and pride you can give those individuals is great. Unfortunately, only about 21% of all enrolled patients actually complete a program nationally, which is again startling. And again, a lot of reasons, you know, they got to get back to work now that we're seeing a younger population can lead to some of that. I like to show Iowa's again, we're double the national average for our completion rate, which is fantastic. I think that would be huge to double that again in the next, you know, 3 to 5 years. And I know there's a lot of initiative with Milligan Hearts, the American Heart Association, American College of Cardiology, and such that are pushing to try to get that up into the 70th percentile, which I think would be fantastic. So ways to improve this utilization. Again, as we mentioned, we are lucky enough to have a system in place from our inpatient standpoint where we can actually refer patients automatically to whatever area they might live in. In a metro hospital, we actually push out to a lot of the rural areas. And I think it's extremely important to make sure that they're still in the loop in regards to referrals. You don't want someone to fall wayside. So having that opt-in, opt-out for physicians where they have to push that referral is fantastic. A lot of facilities have liaisons where they actually, from an inpatient standpoint, the navigators liaisons will go around and actually meet with every patient. Where are you from? This is the closest cardiac rehab. They give them the numbers. Some programs I know as well actually make their first appointment for them. That's extremely encouraging. And it's almost like setting up their doctor's appointment or surgeon's appointment following their procedure or event. Why not have that first appointment for cardiac rehab as well? They offer maps, contact information, extreme amounts of encouragement, which is huge. And those programs that are able to have these, they're blessed. We talked about the early appointments, reminder phone calls from the referring individuals. So if you refer to your own facility, you're going to get phone calls, of course, to try to get you signed up. This is more for the rural entity, you know, making sure, did you get contacted by these facilities? Because it's tough for us to stay on top of everybody, but reminder calls are important. And then, of course, the biggest one is that strength of physician endorsement. You know, when the doc comes in to help discharge or before they're left, to say, don't forget to get into cardiac rehab. Huge entity to have. And of course, the family intervention. What we're kind of after today is having that family member understand exactly what cardiac rehab is and the importance of it, and to know that they can help facilitate a lot of where this individual, this patient needs to get to. And then, of course, as we're getting into technology, apps, text messages, and things like that are important as well for those individuals. As they're younger and younger, texting has become very, very prevalent. And so to incorporate that in some manner is extremely helpful. So these are looking at the benefits of the actual utilization, those individuals that join cardiac rehab, or why you should. So these are long-term studies, but the reduced risks of another fatal MI, severity of any angina or the need for anti-angina medications, decreased hospitalizations, which is huge, fewer ER visits, decreased cardiac event rates, decreased all-cause mortality, which leads into some of our mortality data. So post 1 year cardiac rehab participants, those individuals that attended more than 24 sessions had a 58% relative risk reduction for mortality. Huge number there. After 5 years, a 34%. So mortality reductions extended to all demographic and clinical subgroups, including patients with acute MIs and those receiving revascularization procedures like bypass, and those also with congestive heart failure. Little reference there. So who can refer a patient? This was always kind of the my cardiologist didn't say I needed to do this, or didn't remind me of it, or didn't say anything, but who else can actually refer to a program? So these are site specific. And again, some states it varies. So, but again, primary care physicians, we get a handful of those a month because again, a lot of these are going to come from the surgeons or the cardiologists, but when it does trickle down to the primary care physicians, it's good for them to be knowledgeable of someone that had heart events. Did you do cardiac rehab? If you didn't, oh, you know what? Let's get you referred to that. I think it would help you progress in your care and improve your quality of life. Nurse practitioners and physician assistants, again, it's state specific. I don't have any specific ones that I could push out there to you, but it has been informed to people across the country that they have been able to refer. Typically, we don't see this though, so I want to be very upfront about that. So in conclusion, again, proven to be an effective improving cardiovascular quality and reducing morbidity and mortality. Huge. Despite the evidence of its benefits in being a 1A intervention, it still remains extremely underutilized, and that's what we're trying to work on. Much research is being produced exploring new ways of delivering services and incorporating new technologies. And I had a little snippet where I mentioned the word hybrid. Some programs across the countries are doing telemedicine, which is fantastic. What they'll do is bring you in for X number of sessions just to be able to get a baseline, and then be able to turn you loose because you are still working, or geographically it doesn't work for you to be in a true traditional setting within a center. Also the hybrid, where again, they still come once a week, maybe twice, but then they are given similar entities to do at home, slightly reduced because again, you're on your own, so there's no events or occurrences, but they're able to do it safely for those folks that have shown to be able to be independent on their exercise. And we found this to be some of the studies that are already coming out. The compliance is fantastic. So again, I think we're going to see a lot of programs move to kind of a hybrid environment. Much concentration now is looking at a primary prevention. A lot of your heart facilities are incorporating this primary prevention, meaning if you have risk factors associated with heart disease, they're actually tagging you and prepping you to how you can actually prevent having that event or having those surgeries for years to come. It might be inevitable, but again, what you can do is prolong that and make sure that the process is much easier. And your recovery, when you do have those, is much better. All right, that's all I have today.
Thank you so much for that, Eric. I would like to kind of open it up to any of our attendees. If you have any questions, please feel free to put them in the chat or in the Q&A section. I have a quick question, actually. What do you think we can do more in the rural space to kind of improve that access?
That's a great question. So again, I kind of want to look at, I'll use Iowa as a great example. So we have 99 counties in Iowa, and roughly 90 of our counties, and I believe that statistics is pretty close, 88 to 90 counties are represented with a cardiac rehab. But again, when we get to, more rural, even more than that, where you only have major cities, could be 100 miles away, a lot of it is the education from the primary care physicians. Is it something that they could incorporate? It's doesn't take a whole lot to actually start a cardiac rehab. Of course, you have to outweigh the cost. Is it more beneficial to have this type of environment rather than having people completely end up back in the hospital or the ERs and things like that? When we talked about the benefits in reducing those, I think a lot of it's the communication, as we talked briefly about the hybrid. Hopefully, if there is major distances in between a facility and yourself, can you work with a facility somehow where once or twice a week or once or every other week, you're able to visit actually a facility to be monitored, to get your blood pressures checked, to get your blood sugars checked if need be, to have that safe environment. That's going to be one of the key things. I know there's a lot of initiatives going along around the country right now where they are trying to tackle the rural population more so than the metro. That's never really been an issue. And there's been studies out there where metro participation is fantastic and rural starves a little bit. So it's good to know that people out there are trying.
Yeah, thank you so much for that answer. It looks like we also have a question from Basil. So, are there any resources you would recommend cardiac rehab departments share for patients who may not be able to afford rehab due to insurance complications?
Any resources? It's another good question, complicated question. A lot of it's going to be understanding the tools necessary, be it the exercise and education. When you look at cardiac rehab, it all comes back to a core of exercise and education. The exercise can be touchy. Again, if someone has complications, they have arrhythmias and stuff like that, sometimes it can be life-threatening at times. Again, being in cardiac rehab for 30 years myself, we catch stuff on a daily basis of folks, be it blood pressures, be it arrhythmias within their rhythm, stuff like that, that we have to intervene with a physician to medication changes or even some type of small procedure to where they need to fix those problems. So those are my only concerns in regards to exercise. Education, there's many, many tools out there. American Heart Association has a gamut of great tools out there, and they have a whole section within their website of education stuff labeled under their cardiac rehab. The beauty of what we're living in now is an electronic age where you can actually go out and Google it. And to be honest, there's not a lot of false information out there when it comes to that. So the tools are there. It's just searching a little bit and knowing that you're safely being able to do it. Again, for those that do have complications, I would be very cautious, and I would try as much as you can to utilize a center base as if you could. So I hope that answered your question.
Okay, well, I don't see any other questions in the Q&A. I will give it just a moment, see if we have any others pop up. All right. I don't think we'll have anything else. So I just want to thank everyone again so much for taking the time to attend today. Really appreciate you taking time out of your schedule to come and join us for the new webinar series that the Iowa Heart Foundation is launching. And Eric, if you could, thank you so much. Yeah, so we have a few upcoming webinars. We have one in May, so that'll be on the 17th at the same time as today, and that will be going over hypertension and sodium with one of the Iowa Heart Center's dietitians. So what can be done with sodium pertaining to hypertension? And if you would like to register for that one, the QR code is there, and then I will also put a link in the chat. But that should be all the content we'll be covering for the day. Thank you so much again for attending, taking time out of your busy schedules. We really appreciate it. And thank you to Eric for that amazing presentation.
You're more than welcome.
Okay.